Good evening to all the aspirants present here. We have the speaker here right now, so we'll be starting now. The topic for today is HIV acquired immunodeficiency syndrome, and our organizers are Dr. Akhilesh Tandekar, Dr. Gunadhar Padi, and Dr. Asif Iqbal. And the speaker that we have here is Dr. Bikram Das, who is a consultant infectious diseases in Apollo Multispeciality Hospital, Kolkata. Sir, you may start the session. Thank you.
Thank you. Thank you for the kind introduction, and I'm sorry for the delay. Today's topic is actually HIV infection, HIV and AIDS, but this is a critical care workshop. So I'll try to limit my talk into the critical care complications of HIV and the presentations of HIV, which are actually emergency or we have to manage in ICU. So the ICU admitted HIV patients, that cases will be discussed. It will be a case-based discussion. In between, anybody want to answer to the questions, they can write into chat box. And this is my disclaimer. I'm not an intensivist. I'm a infectious disease physician. So mostly the infectious disease part will be discussed, and few ICU or the critical care part will be there. Focusing on to the HIV, the overview of my talk over next 40 minutes or so will be HIV testing and disclosure. This is because this is one of the important aspects of HIV testing. What are the laws in India, what the NACO says, when to disclose, and how to test and how to treat these patients are all the basic things we need to know. Along with this, we will learn few complications of HIV and some of the case-based discussions of my cases that were admitted in ICU and we have managed it. And what is the approach towards antiretroviral therapy and what you do in ICU, what an intensivist should know about HIV treatment. And at the end, I will discuss on post-exposure prophylaxis because many of the intensivists often have a needle prick and they need a post-exposure prophylaxis for this HIV infected patients. So we will discuss on PAP also. Coming to my first case. So this is a 42-year-old male. Can you see the slide properly?
Yes, sir, it is visible.
No, sir. Full screen, please. Power presentation.
Is it okay now?
Yes, sir.
Fine. So this is the first case, 42-year-old male. He actually was a healthcare worker and he had fever for 5 days with dry cough and had shortness of breath for 2 days, which was actually gradually worsening. So he was admitted in HDU. On presentation, the total count was 3,400, platelet was 1.2 lakh and hemoglobin was 9.2. So he was mildly pancytopenic. Creatinine was a bit raised 1.4. Initially, there was no kidney problems and his albumin globulin ratio was altered. The CT chest was done. As you can see, there is bilateral scattered ground glass opacities. And on day 2 of admission, patient had worsening of shortness of breath and was put on HFNO. Next day, the patient was actually shifted to intensive care unit as he was not tolerating on HFNO and was put on invasive positive pressure ventilation. So with this picture, for this 42-year-old male without any prior history, any other prior comorbidities, do you want to do HIV testing? Yes or no? Anyone want to answer? Is there any clue in this case where we should test for HIV? Yes, in this patient, we have pancytopenia in the first presentation, and also there is a alteration of albumin globulin ratio. So this can happen in HIV, and if there is bilateral scattered lesions without a known comorbidity or a cardiac disease, then we might think of some of the infections or the viral infections that can happen with these pictures. So yes, we can do HIV testing for this patient. Now for testing HIV to this patient without his consent is not possible. So is any consent needed before testing in our ICU? What do you think? Yes or no? Do you need to take consent for every patient before testing? The answer actually is complicated. There are a lot of rules across the world in different countries, and it varies across the country. So I will discuss what is there in WHO and what is there in NACO. As per the WHO guidelines, patients to be informed that HIV testing is being done, and unless they are opting out, we will run the test if we need it. This is WHO 2019 guideline, and there is an encouragement of testing. They say the HIV testing services HTS, and they make a lot of efforts to encourage the testing. What they do, they make the brief key messages and the counseling by the providers. They also message during the couples counseling and encourage testing. Also, they take the related risk reduction and economic empowerment issues, particularly for people who have injectable drug as a habit, or the IDU people, and also they spread some of the motivational message. So with many ways they try to encourage HIV testing, but if they opt out, that is a different thing. But what does NACO say? NACO says that informed consent applies to HIV testing, and it must be a real informed consent and not an implied consent. That means you cannot do a HIV testing saying verbally that I am doing HIV testing for you. You have to have a informed consent, and informed means the full disclosure of the nature of HIV disease. If it comes positive, what are the consequences? If it comes negative, what you are going to think. And the consent must be voluntary, and patient must be able to understand. So this is a quite complicated thing for ICU people, because this patient is on HFNO and later on IPPB, he is not able to sign for his testing. So what can be done for that? So we can have a proxy consent. I will discuss it later on. So for this patient, if we don't ask for HIV testing consent, then probably that becomes illegal as per NACO. And if it is not documented well, then probably it did not happen. So as per these are the legal words we should keep in mind. If the patient is not able to give consent, then we can have a proxy consent from his nearest kin or a guardian, maybe spouse. But again, disclosing to the spouse is also a tricky thing that I will discuss. So anyway, whichever patients, what we do in our practice, whichever patient there is a suspicion of immunosuppressive immunosuppressed state, and we suspect it, and to rule out HIV, we do a PD serology in our setup. There is a pediatric serology in which we get HIV, hepatitis B and C together, and if we get it positive, then we counsel properly and then do further testing. That's what we can do. And HIV ELISA came positive for this patient. Now, how to disclose this? This patient is on IPPB, as I said. So how to disclose it? So there is no healthcare provider except a physician or a counselor shall disclose the HIV positive status to a person, to his or her partner as per the law. No person shall be compelled to disclose his HIV status except by an order that the disclosure of such information is necessary in the interest of the justice for the determination of the issues in the matter before it. Okay, so you cannot compel anybody to disclose his HIV status. Only you can disclose in certain situations, like it is required by the law, or it is required for the administration of justice, or it is in the best interest of the patient. That is, if you disclose it, the medical team treating will be able to treat the patient better and have a better approach. Now, other things are, if you want to protect the another person, that is a partner notification, and if it is necessary for public interest, that time you should disclose it. There are few exceptions. If a physician knows that a HIV seropositive individual is encouraging the third person or the third party, then probably he is able to do this. So in a nutshell, the decision about whether to breach the confidentiality remains with the physician, and it is not imposed as a matter of law. So it is a bit complicated thing, and we should be slightly careful in disclosing, and we should choose the correct person for disclosure. So, if what will happen if somebody discriminates HIV? Suppose a patient of newly diagnosed VLHA has a peptic perforation, and the surgeon doesn't want to operate that, and he is trying to stigmatize and discriminate. Then what will happen? Yes, he is liable for punishment, and the punishment is imprisonment up to 2 years and a maximum fine of 1 lakh. So this also you need to know. You should not discriminate HIV patients. So these are the law and orders. Now I'll come to the clinical scenario. So this was published data in NEJM, and it's a database from 1981 to 2003, and they have calculated all the ICU admissions having HIV patients and the syndromes they have categorized. So maximum admission was with the respiratory failure followed by sepsis, then the neurological conditions. Also, there were some of the metabolic conditions and gastrointestinal conditions, and some of the post-surgical or the trauma care patients had HIV. So maximum was the respiratory. So as a ICU or the intensivist, you must know HIV up to a level. This is also a very great thing, as you can see from 1996 to 2016 onwards. The cause of death in HIV has changed drastically. Initially, the cause was due to HIV, AIDS, or AIDS-defining conditions. But as you have a better HIV therapy or HAART, highly active antiretroviral therapy, the cause of death becomes the same as the aged population in non-HIV. So it is more MI, more non-communicable disease, more a stroke. So the cause of death now for a HIV patient on ART and adherent and well suppressed is like same as the non-HIV elderly patient. Coming to the basics of HIV. So this chart you must remember and you must assimilate. This is the basic of CD4 interaction with the CD4 virology and the clinical situations. If the patient gets an infection, so that is a primary infection, and soon after getting infections, there will be replication of the virus. If the patient is not on PEP, some of the percentage will be infected by HIV, and there will be a viremic phase. In the first viremic phase, there will be a drop in the CD4 count. Later on, the viremia will gradually come down. So during the primary viremic phase, the patient may have a primary HIV syndrome. Okay, there may be lymphadenopathy. We call it acute HIV syndrome. There are some of the lymphoid swellings because the HIV gets seeded, HIV virus gets seeded there in the lymphoid organs, and there will be lowering of the CD4. Gradually, the CD4 recovers and the viral load comes down, and there is a considerable latency periods. For some, it is 5 years, for some, it is 10 years, for some, it is more. And after this latency, there will be gradual lowering of the CD4, and it will be a steady fall, and there will be a rise of viral load. So in that case, some point of time, patient may get constitutional symptoms, and in the later half of this exponential phase of viremia, patient will get opportunistic infections. When the CD4 count is quite low, especially less than 200, patient may get a lot of opportunistic infections, and the presentation will be like that. So the initial part, the viremia will be presenting as acute HIV syndrome. That will be just like a mononucleosis syndrome. Patient may have a rash, throat pain, lymphadenopathy, and some of the joint pains may be there. Later on, patient may present with the constitutional symptoms. But the in between this latent phase, how to make this, how to understand this one, and how to diagnose in this phase. This we can do only if we test properly, because most of the patients will be asymptomatic, the young population in this latency phase, and they will be going on spreading the infection. So unless you test during this latent period, you won't be able to diagnose HIV. So this is the reason, if we suspect it, even if the patient is asymptomatic, we should do the testing properly. So this is a question: is a newly diagnosed HIV patients, people living with HIV AIDS, we call PLHA, had a platelet count of 25,000 without any other alternative etiology for thrombocytopenia. So with this platelet count, what is the WHO staging of HIV? It is stage 1, 2, 3, or 4. Anybody want to answer? whenever you get this much of low platelet count, so it will automatically come into stage 3. You need to read about these stages because these stages are very important to stratify and prognosticate the HIV positive patients. Stage 2, up to stage 2, it is not a severe disease actually. Stage 3 onwards is becoming a bit dicey because some of the cases of case stage 3 and some and stage 4, there is not much difference. The thrombocytopenia 50,000 and below 50,000 will be included in the stage 3, whereas if you get a lymphoma or a disseminated TB, HIV encephalopathy, or the HIV is defining conditions, the clinical staging is stage 4. So this stage, whose staging you need to remember, and this also corroborates with the CDC staging. I will discuss on that. So in 2014, the CDC has a staging stage 0 to stage 3, and they have tried to uh, correlate clinically as well as the CD4 count. But frankly speaking, there is, I mean, many of the cases you won't get this much of discretion and this correlation with the CD4 and the clinical conditions. But to remember it, stage 1 and stage 2, the CD4 will be above 200. Okay, stage 1 above 500, stage 2 above 200. Below 200, it becomes stage 3 as per the CD4 is concerned. But not only this count, percent is also important. So 14% of the CD4 correlates with the 200 cells of CD4. And at the same time, if you have the HIV AIDS defining condition, so this becomes AIDS. So WHO category 4 is probably CDC 3, and 2 is marched with WHO category 2 and 3, and probably stage 1 in CDC is WHO stage 1. So these are the revised classification system, and they have a stage 3 defining opportunistic infection. These are almost same like the conditions I mentioned in the WHO stage 4. But yes, there are some extra points that you can always remember. So what are the classes available for antiretroviral drug coming to the treatment phase? So this 4 we already know: NRTI, NNRTI, PI, and INSTI. Nucleoside reverse transcriptase inhibitor, non-nucleoside reverse transcriptase inhibitor, protease inhibitor, and integrase inhibitor. But there are a lot more, and there are many other HIV drugs on the pipeline. I'll not go into details of all this, but then these 3 classes I think I need to tell because we are already using this some of the cases. Maybe you need to know about this fusion inhibitors, CCR5 inhibitors, because they may ask you for a question or the MCQs. Okay, so the fusion inhibitor, enfuvirtide, CCR5 inhibitor like Veraviroc, and the new one, CD4 directed attachment inhibitor, lenacapavir. Okay, so these 3 classes you can remember for the MCQ purposes, but actually you are using a combination of NRTI, 2-NRTI, and the integrase inhibitor. I will discuss. The capsid inhibitors as well. Their capsid inhibitors are the lenacapavir. Capsid inhibitor are the lenacapavir, and the CD4 directed inhibitors are also there. Okay, so this is the schematic diagram actually. So as you can see, after binding with the CD4, they attach to the cell, and then they get fusion with the membrane of the cell, and then the genome, that is the RNA, goes inside, and there is a reverse transcription. After this reverse transcription from RNA to DNA is formed, and the DNA gets integrated into the host DNA, and they use the machinery as per their will, and they make their own protein and their own capsid. Now they assemble, and after that they come out of this cell membrane after this budding, and they release. So we get more and more new HIV virus particles. So this is what they do with our body cells. Now coming to the clinical discussions. This is the first case of clinical discussion. This is a 47-year-old male diagnosed with HIV-1 positive and was on ART with lamivudine, abacavir, and nevirapine for last 1 month. CD4 was below 200, it was 163. And for this patient, after starting this treatment, patient started having these lesions. You can see mucosal lesions involving the mucocutaneous area, also the palm, and in the skin, there are some of the vesicular lesions all over the body. So what do you feel? What is the most culprit drug for this kind of rash? Is it lamivudine? Is it abacavir or nevirapine? Or none of the above? This is not related to ART. Anyone want to answer this? You can write in chat box. Yeah. Yes. So somebody answered it is nevirapine. Yes, nevirapine is the most notorious thing, okay, to cause this. So what is the condition? What is the condition involving the mucocutaneous area, the whole body, palm and soul? What is the condition?
Steven Johnson syndrome.
So probably that is SJS10, okay? So as per the involvement of the body surface area, you have to categorize it. What is it, SJS or a 10? And the possible etiology is nevirapine, as you already mentioned. So what will you do as an intensivist for this patient? You need to know that nevirapine can cause 65% of the eruptions, and it can occur within the first 6 weeks of therapy. The serious reactions, SJS10, and the incidence is 0.3% in patient undergoing nevirapine. It is actually rare with abacavir, but abacavir hypersensitivity entity is there. I will discuss it in detail. But there are case reports of 10 with abacavir, and it has happened after 4 months of starting abacavir, lamivudine, also darunavir and ritonavir. So we need to be very, very careful, sir. We don't know which drug is going to cause this SJS10. Even up to 4 months, we can get this. Coming to abacavir hypersensitivity, though we see it very less often, but then you need to know the entity that abacavir hypersensitivity is something very fatal, and if it happens, we should not re-challenge abacavir again. We can do HLA-B 5701 for ruling out abacavir hypersensitivity, but then this test is not well available. But as the incidence is very low, we always say if we have to start abacavir, we give it and say okay, if there is any fever, rash, nausea, vomiting, or any respiratory symptoms, there may not be a rash. If there is any respiratory symptom, a flu-like symptom after starting abacavir, then stop it and meet the physician. So abacavir hypersensitivity, if we suspect, do not give again. Okay, and one more thing to remember that unlike other DRESS syndromes, that is a drug-related hypersensitivity syndromes, you may not get a peripheral eosinophilia and you may not get a raised liver enzyme. So this is very, very important. And what is the hallmark? If you stop the abacavir, the rash will completely disappear. Rash or the symptoms of the flu-like symptoms will completely disappear within 72 hours of discontinuation and never give re-exposure. And do not forget if the patient is already on Bactrim, that is trimethoprim sulfamethoxazole, because this is more notorious and this is more often causing this SJS and 10. So always stop these sulfur-containing drugs in this scenario. Coming to the next case, this is a 31-year-old male, known case of PLHA, having a body weight of 56 kg. It is non-diabetic. Was on ART for 6 weeks, 3 weeks, sorry. 3 weeks was on tenofovir, lamivudine, and efavirenz. And also there was cotrimoxazole prophylaxis ongoing. You can see the baseline CD4 count, only 1. This patient had GI symptoms, nausea, vomiting, asthenia, some of the muscular weakness. So it is almost 3 weeks after starting this ART with this very, very low CD4 count. The patient was actually conscious, oriented, but tachycardia, tachypnea was there, and the heart rate, as you can see, is the borderline. BP is 100/60. On examination, patient had pallor, dehydrated, and there was diffuse abdominal tenderness. So he was admitted in ICU with this hemodynamics. The blood reports came, hemoglobin was 9.4, WBC count was lower side, it was approximately 3,500. Platelet was 1.5 lakh. Sodium and chloride were almost okay. Bicarbonate was a bit low, 11.2. There was transaminase. AST was the range more than 1000. ALT was more than 400. Alkaline phosphorus was more than 787. However, this patient was negative for HbS/Ag anti-HCV. MIS lipase was also within normal limit. So this young man with newly diagnosed PLHA with a very low CD4 count and started on ART with tenofovir, lamivudine, efavirenz, presented with this unstable hemodynamics, tachycardia, tachypnea, dehydration, abdominal pain with a low bicarbonate and transaminitis. What are the possibilities? And what is the next investigation you want to ask as an intensivist? Any answer? Okay, as an intensivist, definitely we will do a USG abdomen, and nothing was there. There was only mild fatty changes. You will definitely do an ABG. What you can see in this ABG? You can see in this ABG, there is acidosis, right? There is metabolic acidosis with an anion gap of 25. So anything from this, you can guess what can be the causative probable diagnosis with this case. Is it a sepsis? Patient is hemodynamically getting unstable with an abdominal pain without any obvious focus in the abdomen. Can it be sepsis? If it is sepsis, where is the source? If it is ethanol toxication, we did not get any history of ethanol though, but we can get this kind of picture. Iron gap and with lactic acidosis, we can get this. Is it drug induced? Is it ART induced? Or none of the above? Any answer? Anyone want to answer? You can. So okay, one of you want CCT abdomen and lamivudine induced DILI they have suggested, but then it is probably not a DILI. It is a very acute thing, and the patient had a predominant. Usually in DILI, you don't get this much of abdominal pain and this much of hemodynamic instability. Patient did not have this much of vomiting, so that the patient will have a hypotension. And as you can see, the lactates it is also 12. So this is kind of a type 2 lactic acidosis. So what can be the ground of this type 2 lactic acidosis with this presentation? Pancreatitis, no, pancreatitis we ruled out actually, and CECT we could not do because of the hemodynamic status at that point of time. Amylase lipase were low. Anything else? Well, so let us see. What are the causes of type B lactic acidosis? Yes, liver disease, malignancy, especially lymphoma, medications, total parenteral nutrition, NRTI therapy, non-nucleotide reverse transcription inhibitor therapy, thiamine deficiency, mitochondrial myopathy, congenital lactic acidosis, trauma, excessive exercise, decay, and ethanol intoxication. This all can cause type B lactic acidosis. For this patient, probably ongoing NRTI were the causative agent. Now, what are the NRTI patient was on? Patient was on tenofovir and lamivudine. Patient was on lamivudine, tenofovir, and efavirenz. Efavirenz is NRTI. So, what are the incidence rates with this drug-induced type 2 lactic acidosis? It is very low actually. The incidence of symptomatic severe hyperlactatemia with heart was lower at 1.3 to 20 cases per 1,000 treated person years. Okay. So jalcitabine followed by didanosine, stabudine, lamivudine, then girobudine, and then abacavir probably can cause type 2 lactic acidosis. It is actually rare with lamivudine and low potency to cause mitochondrial toxicity with lamivudine. So this lactic acidosis are due to actually mitochondrial toxicity. So the incidence is rare, but it can happen. Which patients will have an NRTI induced lactic acidosis? Those who are obese, female gender, pregnant patients, liver injury, and low CD4 count. So this patient, irrespective of very low CD4 count, they may have lactic acidosis. So never forget lactic acidosis in patient on ART having abdominal pain and um, type 2 type B lactic acidosis or uh, unexplained acidosis and hemodynamic instability. Coming to the next case. This is a 50-year-old male, newly diagnosed HA, PLHA, ART naive, and had a chest mass extending to the left axilla. This is one of the cases I was too much surprised because this patient also had a hemodynamic instability on presentation with a very low CD4 count, and we had to admit the patient on ICU. And patient has this lactic acidosis was very refractory. We tried to look for the sepsis, but all the cultures, everything came negative. Because of the clinical situations, we could not do the biopsy of the chest mass, the initial part, but later on we could do it, and we found that there was a high-grade B-cell lymphoma. Unfortunately, the patient succumbed to death after 4 days of hospitalization. So this was a case of refractory lactic acidosis in a naive PLHA presenting with a chest mass, and that was a high-grade B-cell lymphoma. So we should be very, very careful with this very high refractory lactic acidosis. Coming to next case, this is a 31-year male with considerably well body weight of 67 kg, had fever and dry cough for last 1 month. So it's a subacute cough with fever. And patient was outside hospital treated as a right-sided pneumonia, and he received IV meropenem for 14 days. Had a fever of 101 and hemodynamic stable with a heart rate of 108 for the temperature. Patient also has a seborrheic dermatitis at the presentation. Hemoglobin was low, platelet were low, so there were bicytopenia again, and as you can see, the AG ratio was altered. Again, the patient had a CT chest here, and that shows a mass with cavitation. So it was a non-resolving pneumonia with a cavitary lung lesion. Patient came to be HIV positive, and the CD4, as you can see, is 36. So what are the differentials? Can anybody type? What are the differentials? Newly diagnosed PLHA with a cavitary lung lesion. Aspergillosis, yes, possible. Anything else? Aspergillosis, TB, lung abscess, okay. Is a subacute presentation, and the patient was treated with antibiotic outside but did not resolve. TB definitely comes into picture, but then is other things possible with this presentation? Okay, let us see. This patient's BAL was done. We could do a BAL, and expert was negative. Culture had no growth. Smear on modified Jeren stain showed a partially acid-first branching bacilli, and it was suggestive of nocardia. So in a cavitary lesion in HIV positive patient with low CD4, TB, histoplasma, aspergillus, these are possible, but the other things are nocardia and rhodococcus. So you must not forget these two differentials, okay? And definitely lung abscess and any other as per the epidemiology, you can get blastomycosis, something like that, or any other invasive fungal infections. You can have a mucor as well. So one aspect is the bacterial, one aspect is the fungal. Both are possible. Even two organisms can be present simultaneously in a low CD4 patients. So we should be very careful in diagnosing and interpreting the reports. Fungal smear was negative for this patient. So patient was planned to start ART. So will you start ART with this patient? So now we know patient has nocardia. Will you start treatment for this patient or want to do any other investigation? Yes or no? Okay, once you get a pulmonary nocardia in a low CD4 patient, don't forget to do a brain imaging, because some of the percentage of the patient will have a brain nocardia. So you need to rule out that, because if you start ART, then there is a chance, slight chance though, there is a chance the patient may have a CNS IRIS, immune reconstitution inflammatory syndrome, and that will cause a palliational edema, and patient may have neurological issues, severe neurological issues. So always be careful. Patient, we have a diagnosed pulmonary nocardiosis, so you rule out CNS lesion. This patient MRI was done, and we got uh, lesions in the brain as well. So there was a review of literature in which 2 out of 54 patients were considered to have CNS nocardiosis without any neurological abnormalities. So not necessarily all the patients will have neurological abnormalities with CNS nocardiosis. Many of the patients will be asymptomatic, must do a brain imaging. So what are the sensitivity of nocardia? These are the common species of nocardia. Not all the centers are doing nocardia speciation and nocardia cultures. If we do the cultures, then we can know what are the sensitivity pattern. But having said that, if we don't have this infrastructure, then we can just choose 2-3 medicines that will cover almost all the common species. So nocardia farcinia is something we need to remember, because it is resistant to Bactrim or the thimethoxam sulmethoxazole. So if we suspect nocardia farcinica, which you see in this part of the world, we should keep linezolid in our regime. So linezolid is the only component probably which covers all this nocardia species. Other effective drugs are trimethoprim, samsozole, ceftriaxone, imipenem, amikacin, and amoxicillin probably. So we should choose very carefully, and if there is any CNS lesion, we should choose those medicines that will have a good brain penetration as well. So the focus of infection is very important while choosing antibiotic regime. This patient was started on ART as well. Patient was given tenofovir, alafenamide, MTC-tabine, and dolutegravir regime, and was followed up with OPD. Then patient had multiple time drug modifications for different reasons, for the side effects and all. And ultimately, we could complete 6 months of therapy, and the viral load, HIV viral load, is not detected. Patient is doing well, and now is quite good looking, 95 kg, and now wants to go for gym. Okay, so what are the medicines you should choose, recommended regime? So this is a EACS guideline. I will not complicate with, I'll just come to the real world choices. So what you give is a combination of, sorry. So what you give, a combination of a integrase inhibitor along with a 2 NRTI. 2 NRTI are usually tenofovir alafenamide or tenofovir disoproxil, and another one is either lamivudine and or a MTC-tabine, or you can choose a dolutegravir or bictegravir from the integrase inhibitor group. So these 3 drug combination you can make. Now 2 drug combination also has come with good evidences. They can be given as an initial regime, but then you need to be careful in these patients, especially who has a pre-treatment HIV RNA more than 5 lakh. You cannot give 2 drug treatment for this group. If the patient is known case of active hepatitis B co-infection, then you cannot give, because if the patient have hepatitis B and HIV co-infection, you need to give 2 active medicines that will work on hepatitis B. And number 3, if we don't know the genotype, especially this is important in those areas where they are already exposed to integrase inhibitor like cabotegravir. I'll discuss later on. So those who are already exposed to integrase inhibitor, in those you cannot choose a double drug regime with dolutegravir and tenofovir. Coming to the next case, this is a 61-year-old gentleman. Known case of diabetes and hypertension, had an acute onset of slurring of speech and facial deviation. I had a recurrence of same symptoms later in the day thrice. There is no history of seizure or loss of consciousness or headache, and no weakness, no autonomic disturbances, no history of fall. Provisional diagnosis was a TIA. transient ischemic attack or a severe, and he was admitted outside with these transient symptoms, one under a neurologist, and was started on anti-epileptics and antiplatelet. MRI was done, which showed multiple ill-defined subpyre lesions involving the supra and infraterritorial compartments. And there was mild leptomeningeal thickening. Patient was started on empiric ATT on September and was clinically doing well. After a month, patient again admitted to hospital with 3 days of fever and seizures. Now, patient was admitted in ICU. Again, MRI was done, and there are multiple ring enhancing lesions without any significant changes compared to the previous MRI. And they said you rule out the metastasis. Lab investigation showed blood investigation was normal, PET CT was planned, and it was done, which showed low-grade FDG avid and non-avid nodular lesions in both cerebral and cerebral hemispheres, likely infective, and also low-grade FDG avid cervical, external iliac, and inguinal nodes, likely inflammatory. Now, what to do next? You start MDR TB treatment as the patient is already on TB treatment, but it is not responding, or you start a steroid, or you reevaluate, or you optimize the anti-epileptic. So what will you do? 1, 2, 3, 4. Put your choices. You can write your choices. What you want to do next with this patient? Having the CNS lesions, we don't know what is the thing. Yes, we want to reevaluate. So why the patient is not responding to TB treatment, which is empiric? Is there any other diagnosis, or the patient have an underlying immunodeficiency status? Remember that for this patient, I did not tell this patient is having HIV or not. The patient did not come to ICU with a HIV positive status. So you should be very, very careful. You should reevaluate. Of course, you should reevaluate. So what to do in a reevaluation? Serology was done, and patient was started on ART after 1 month of ATT with tenofovir, emtricitabine, and efavirenz. That time it was an efavirenz time, 2019. So the patient was given efavirenz, and CD4 was 33 in September, and viral load was in lakhs. Patient was discharged well on ART and ATT and steroid. Surface antigen was negative, HCV antibody was not detected, and HIV ELISA was detected. As I said, third admission, patient again got admitted with focal seizure involving the right upper and lower lip. Now this time CT brain was done, which showed multiple indefined hypotenuse lesion in the occipital, parietal, temporal, frontal, also in the putamen, on right caudate and left putamen. And they said it can be granulomatous lesion, etc. Sensorium was worsened, and the patient was with this shifted to our center. As you can see, scattered, lot of scattered lesions. So what to do next? Patient is already on ATT, but not responding. Is it something else? What to do? You do a CSF, or you increase the steroid dose, suspecting is it a IDs? Already the patient is on steroid. Or you counsel and report the patient to other hospital because you are not able to treat the patient in your hospital, or you call an ID physician. What to do? What do you want to do? Yes, somebody want to call ID physician. Yeah, thank you. Anyone else? Okay, so we are not going to refer the patient. We can get the consultation and see what happens. So what are the other possibilities we can explore? Patient can have CNS toxoplasmosis, can have CNS lymphoma, cerebral cryptococcoma, or a tuberculoma. So these are the differential diagnosis of ring enhancing lesion in an immunosuppressed patient. We should not forget. Okay, some of them we can easily diagnose, and some of them we have to suspect and give treatment. So the patient was undergone serum toxoplasma IgG blood test, and it was positive, whereas cryptococcal IgM were to lateral flow assay, which was negative, and patient was started on treatment for toxoplasmosis. The dose is trimethoprim sulfamethoxazole. We can use IV medicines initially, 10 mg per kg in 2 divided doses, and TB medicines were continued. For some of the patients, with this CNS lesion, maybe we have to continue both toxo and TB treatment together, because most of the time we may not get appropriate biopsy or appropriate tissue sampling for the location of the ring enhancing lesion. So we have to continue both of them, and gradually when the patient urologically improves and time of 4 to 6 weeks is elapsed, then we can start off ART. So what is the treatment for toxoplasmosis? The first line is pyrimethamine and sulfadiazine combination, but we don't get this combination often. So we have to treat with trimethoprim, salmeterol, initially with IV, later on we can put oral, and the duration will be 6 weeks. Later on, we have to continue the medicine for as a prophylaxis until the CD4 count is more than 2 cells for 6 months. That is 2 intervals. If the CD4 is more than 200, then only we can stop trimethoprim, salmeterol. This is called secondary prophylaxis. Okay. Coming to the next case, it was a case from Nodia, a 23-year-old male, newly diagnosed, had a fever for 6 months, chronic fever, with swelling of left side of the neck for 2 months, had a headache and extreme fatigue for last 5 days. For last 2 days, patient had altered sensorium. Hemoglobin again down 7.6, WBC 3000 around, and platelet also 75,000. So again pancytopenic with an alkaline phosphatase of more than 400. So this kind of patient with having extreme fatigue, headache, and altered sensorium with a chronic fever, definitely we should think of some encephalopathy or some encephalitis thing. So the CSF was done. But as you can see, CSF had only 2 lymphocytes. Glucose was normal, protein was 45 normal. It was RBC, this kind of bloody tap. RBC was 250. But the patient was pancytopenic and we did not have a diagnosis. So we had to do bone marrow. We did a marrow. You can see there is a capsulated organism there. I have pointed out with an arrow. And the blood culture, you can see this thing. Can you guess? Can anybody guess what is this? Any answer? What it can be? Blood culture showing this organism, and the bone marrow shows this capsulated organisms. What is this? So I'll try to give you some clue. As you can see here in blood culture, you can see this budding thing. So this is something that matches with the budding yeast. Okay, but this is not candida. Then what it can be? Which is having this capsulated look in the bone marrow, and this fungus kind of thing budding yeast in the blood. Yes, Cryptococcus. Some people answered. Great. So this was a case of disseminated cryptococcosis. So how to treat disseminated cryptococcosis? So there are a lot of regime. Okay. Initial part, there is a combination of flucytosine with liposomal amphotericin B or flucytosine with fluconazole. Later on, you consolidate it after this induction, and you consolidate for 8 weeks, and then you continue the maintenance therapy till the CD4 is better. So a lot of regime are there. I'll just focus on one regime that we often use is a combination of liposomal amphotericin B along with flucytosine for 2 weeks. And then we give the consolidation regimen of a higher dose of fluconazole, that is 800 milligram of fluconazole for 8 weeks duration. And then we give the maintenance dose of fluconazole with a 200 milligram. So when to start ART? Anybody? Any questions? Okay. So if we get a cryptococcal meningitis, when to start ART? So it is better to defer ART for 4 to 6 weeks after the initiation of antifungal treatment, because there is high chance of cryptococcal meningitis related cryptococcus meningitis related IRIS, which is at times very fatal. So we should be very careful. And what is preemptive therapy? Suppose the patient has a CD4 of 150, that is less than 200. This kind of patient, we should often send serum cryptococcal antigen. And if the cryptococcal antigen comes positive, and then we do a CSF, but the CSF looks normal. So the patient has some cryptococcal antigen in blood, but the patient has no manifestation. Should we treat the patient? Yes, we should treat the patient because the patient has very low CD4. And this is called the preemptive therapy for cryptococcus. The dose is 800 milligram per oral for 2 weeks, followed by 400 milligram for 8 weeks. There is an update of treatment of cryptococcus. We can use single dose liposomal amphotericin B. The dose is 10 milligram per kg, and the outcome they have shown in this paper in NEJM that it is a similar with the standard of care as in WHO. Coming to the last case, probably this one is 50 or 54-year-old woman having fever and difficulty in breathing and non-productive cough. No history of palpitation, radiation of chest pain, and there is 9 months of history of weight loss. Okay, so till now we did not know the HIV positive status. He is also ex-smoker and had a 7-pack-year history with this chest. It looks almost normal, right? Only some lower zone, there is some opacity in the perihilar area. As you can see, the blood pressure is quite in the higher side. And chest-wise, patient was almost normal. The saturation was 95% in the room air, but there was no breathing problem. So what do? You treat the patient as CAP, community-acquired pneumonia, or you do a CT chest, you do a bronchoscopy, or give ADT. What to do? Treat with antibiotics, do a CT chest. Yeah. So definitely you should do a CT chest for this patient. The suspicion, it can be a lot of things. You can see there are a lot of GGO bilateral, and the HIV ELISA also came positive. So now what is the probable possible diagnosis with this picture? Quick answers. Bilateral GGO. Yes, PGP. So pneumocystis pneumonia is the first thing we need to rule out. Other things are the CMV infections or other viral infections that also can cause similar type of pictures. So definitely we should rule out PJP. We cannot rule out it easily unless we do a bronchoscopy or a good amount of induced sputum. But what we can do, we can have a biomarker like beta-D glucan. If it is more than 523 picogram, then it gives a suggestion. Also, some LDH we can do that can give a suggestion of possibility of a PCP infection, but probably BDG helps a lot in our clinical practice. So it can be a viral pneumonitis, yes, it can be hypersensitive pneumonitis, fluid overload state, or some opportunistic infection. So with this HIV background, definitely we should first rule out opportunistic infection and then only think of other things. CD4 come out to be 12, LDH, as you can see, is more than thousands, viral load was quite high. So possible OI was the PZP, and beta-D glucan was also very high. CMV PCR was also positive, but it was not very high, 382. There is no cutoff. But the BAL probably was not done for this patient, and we have treated as PCP infection only. And the patient subsequently had PCP PCR positive from BAL sample. We did a PCR. It was a positive test. So it was a case of PCP pneumonia in newly diagnosed PLHA with a stage 3. CDC stage 3 and WHO stage 4 disease. So the treatment of choice is the trimethoprim salmeterol. The other choices, some of the patients have the severe cytopenia. We cannot choose trimethoprim salmeterol. In that case, patients we give clindamycin plus pymaquine, and we adjust the dose accordingly. So WHO TB guideline, this thing we should remember in one aspect, this is based on the Camellia trial where the CD4 count is less than 50, they say you can start the ART within 2 weeks of treatment. But if the CD4 is more than 500 but less than 200, then you can delay the treatment up to 8 weeks. But this is not for the TB meningitis. If there is TB meningitis, then you should delay the treatment maybe 4 weeks or 8 weeks or so to reduce the chance of TB IRIS. So I'll not go into detail of this. And this was a viral gastroenteritis with norovirus refractory. I'll not go into all detail. Only thing I want to show, okay, what are the causes of HIV diarrhea? It can be opportunistic pathogen, and the protozoal diarrhea is most common. Cryptosporidium, isospora, microspora. Suppose you are sending some GI pathogen panel. Also, always remember this pathogen panel does not contain many of the organisms that can cause HIV diarrhea. Like it cannot detect TB, it cannot detect MAC, it cannot detect microspora. Okay, so be very careful. Always send stool for modified gelatin stain in a HIV patient with diarrhea. Also, the virus can like norovirus, CMV, Salmonella, Shigella, Campylobacter. This can also cause diarrhea. Don't forget that not only the infection, some of the non-infectious causes of diarrhea are also there in HIV, like HIV enteropathy, autonomic neuropathy, chronic pancreatitis, etc. And if the patient is on PI, protease inhibitor, it can cause leaky flux diarrhea. Also, antiretroviral therapy in ICU becomes a challenge in a diarrhea patient because there are a lot of interactions, drug delivery problems, and the treatment strategy should be very much important. So, when should you start a HIV newly diagnosed HIV patient with ART? Suppose the disease the patient is admitted for is related to HIV, then definitely we should think of treating it, but it depends on the CD4 count. If the CD4 is below 200 and there is no CNS lesion, probably we should go ahead with the treatment with the ART. But if the CD4 is more than 200, we should first treat the condition and then we can later on go for a HART. Okay. So treating the HIV is not an urgency in an ICU. Always remember it, and case to case basis we need to decide. Always get a HIV specialist consultation. Oh, these are the side effects we should remember. I'll just focus on few. If you get a laxatic acidosis, I already told what are the causes. Nephrotoxicity in tenofovir can cause, and hepatotoxicity can be caused by all of the antiretroviral except especially nevirapine. Coming to the post-exposure prophylaxis, the last topic. So once you get prick with a HIV positive patient, there are definite exposure codes, and the source code, if the exposure is quite high, is a large volume major splash that comes in the under the EC2, or there is a hollow bore needle or needle stick injury, then comes in the EC3. So this EC2 and EC3 are the high risk exposure. And the source code, if the patient is having high viral load, patient is untreated, or even if the patient is treated, we should think of source code 2 onwards. And recommendation of PEP comes. Post-exposure prophylaxis, initially what we give are the same as we give treatment for the HIV. That is a tenofovir or TAF, FTC or emtricitabine or lamivudine, and the dolutegravir combination for 28 days. And most important to remember is that you should start the PEP within 72 hours. So coming to the end, take home message. So HIV testing is very important. Unless we test, we won't know the status, and we will miss many of the opportunistic infection and we won't be able to diagnose this. Okay, opportunistic infection as a part of the syndrome and should be kept in mind. Many of the patients may have these CNS symptoms or some lung symptoms. Do not forget that these syndromes may be caused by these organisms and the probable organisms. If we don't get the correct answer, we should treat both of them until we get a clinical stability. Multiple infections can happen in low CD4 patients. If we get one infection, we are not always happy. If the patient is not improving clinically, we should again rethink, we will evaluate. Patients should be monitored for the adverse drug reaction, very important, and the drug-drug interaction, especially with the protease inhibitor. Dolutegravir is quite safe for interaction issues. It is not much affecting the other interaction, but the yes, IFA range has some problem. Standard precautions should be taken for all the patients, even if HIV, non-HIV, while working in ICU. Always maintain standard precautions, because someday you may break and then you are worried, okay, what happened to me? What will happen to me? And PEP can be considered if there is a exposure. So I have taken the guidelines from WHO, NACO, and the individuals guideline from EACS, DHS, and IAS USA. So you can go through this line. Especially, I'll recommend to you to go through NACO, WHO, and DHS guideline. These are all good. Thank you for your patience. Any questions?
Aspirants, if you have any question, you might ask. You can ask now.
Okay, I got a questions. Is from Indonesia and says if a HIV positive patient do routinely need antifungal? No, they do not need antifungal routinely. As I said, suppose a patient is newly diagnosed and is having low CD4 below 200, and we ask for a cryptococcal antigen in serum, and it is positive. Now we do a CSF. CSF test is negative. So the patient is probably not having CSF or cryptococcal meningitis, but the patient will need antifungal. In this scenario, we call it preemptive therapy, and we give a fluconazole of 800 milligram for 2 weeks, then 400 milligram for 8 weeks. So this is the thing we should give without a known fungal treatment. But definitely not all the HIV positive patient will need routine antifungals.
So that's all we have the question for today.
Fine. Then I'm concluding the session. Thank you so much.
Thank you, sir, for being with us. The class was really informative. Thank you all the aspirants for being present. You may leave now. Thank you.